for many months, we ran this different programs in different formats in our Corneal Society monthly webinars. But one of them, which is ever popular and which is beautifully conducted by Dr. Paras, is Kera Grand Round. Beyond any doubts, this thing has actually created its own place in our webinar space, and all credit goes to Dr. Paras for conducting it beautifully and maintaining it to the level where it has sort of become a ritual for us. As everything has to come to an end, so this year's grand round would be coming to end with this grand finale. And what can be a better fitting reply than having a beautiful illustrious panelist with an amazing topic out there, and where we are going to have feast today for all of us, and really looking forward to it. And I'm so thankful for each one of you to take out your time and being here and spending your valuable time to teach all of us, and really looking forward to this. Over to you, Dr. Paras, and we are really looking forward to this wonderful webinar.
Thank you, Himanshu, and I welcome all of you to this Kera Grand Round kind of finale, as Dr. Himanshu mentioned. Today we have stalwarts on the panel, and amongst them, few of them are heading the cornea unit at All India Institute of Medical Sciences RP Center. And the chief of that group is Professor Jeevan Singh Titiyal. We all know Titiyal sir. If I go on to introducing everyone, each of them, probably it would take away the whole session. So with that, I would like to just say that he is joined by the team, Professor Radhika Tandon, Professor Namrata Sharma, Professor Tushar Agarwal, and Professor Rajesh Sinha, Professor Vanati, and Dr. Nupur Gupta. And we have many others from RP Center. And I'm sure that this particular session is going to give you a feel that we are sitting in an RP Center class kind of a thing. Those of you who have not studied at RP Center would have certainly that feel. And with this, I would like to hand over this to, Professor Titiyal sir for a few words, and then maybe Praful can take over and start the session. Sir, we are very happy to have you here, and I welcome all of you again on the board.
Thank you very much, especially Himanshu, the president of Corneal Society of India, and Paras for giving this opportunity to RP Center to do this Kera Grand Round, which is, I think, one of the most popular sessions has been there with the CSI. And as Himanshu said, it's the finale of this year's Grand Round. As we all know, cornea is such a typical structure, and so many things are associated with the cornea, with local disorder, systemic disorder. To given a topic which is so interesting, impending and the corneal perforations. I think the entire session been well designed by Paras and Perful, which covers the autoimmune disorders, infective keratitis, non-infective disorders, ocular surface. Everything is well covered, and I feel it will be very interesting discussion for all our people who joined us today. And on behalf of RP Center, the faculty of Cornea Unit, I would like to welcome all of you. And again, thank you from our heart that this will be a great session. All to you, Paras and Perful.
Thank you, sir. So we are going to cover the entire spectrum of corneal perforation. We have Dr. Gunjan Verma from Ahmedabad and Dr. Geeta Behra ma'am from Jipmer, Puducherry. They will be covering how to manage cases of small corneal perforation. We have Dr. Dipali Singhal from Bhubaneswar. She is going to cover how to deal with perforation which are a little bit larger in size but not suitable for therapeutic PKP. Then we have Dr. Amita Kaul from Narayan Netralaya, Bengaluru, and Dr. Amrita Mohanty from LVP, Hyderabad. They will be dealing with cases how to manage when they are associated with autoimmune component. And lastly, Dr. Sarath from RP Center and Dr. Neha Jain from Ambala. They will be covering the section that covers how to manage cases of large corneal perforation. So with this, I now request Shabina to please play those two videos that covers the management of small corneal perforation.
Good evening everyone, myself Dr. Gunjan Verma Shah. I will be talking about role of tissue adhesives and bandage contact lens in corneal perforations. It is described for perforation in less than 3 mm in size. There are two types of glue, that may be non-biological cyanoacrylate and biologic, that is fibrin glue. Cyanoacrylates undergo polymerization upon contact with water and weak bases causing them to harden. The various techniques have been described. It may be done over the slit lamp or in the operation theatre under aseptic precautions. This may be done under topical or in the local anesthesia. Non-compressing lid speculum has to be used to avoid pressure on the eye. We have to examine patient thoroughly and explain the patient in detail about his condition. Sedal test, fluorescence staining, documentation is very important. Detailed consent has to be taken, and explain in beforehand about other methods or surgical interventions that may be required in the future if glue is ineffective. Pulse and oxygen saturation level monitoring has to be done, and SOS standby anesthetist may be called upon. Debridement of necrotic epithelium tissue debris has to be done. I use 15 number bleed for the same, and look out carefully for any impacted foreign body. Glue may be applied using 27 gauge or 30 gauge needle or 15 number plate. I use 15 number plate. Sterile plastic drip puncture method has also been described, and anterior chamber is needed to be formed before application by air or visco if there is iris plugging, and apply bandage contact lens after the glue is dried. Patching for 6 to 12 hours may also be done if the patient is traveling, as it will alert other co-passengers about his eye procedure or the surgical intervention. Give IUP lowering medications in the post-op period, and it may be removed after 2 to 3 months. Careful scraping can also be done if there is active ulceration, but it has to be done very gently. There are few complications that has been advised, that has been described, that may be tissue toxicity, foreign body sensation to the patient, raised intraocular pressure, corneal vascularization, or need for other surgical intervention like tissue adhesive, like Tenon graft or TPK if glue BCL is failed. In this case, 52-year-old male who had perforated corneal ulcer, and he was suffering for like 3 to 4 months, and he was referred for keratoplasty, and we can see frothy discharge over the lids due to continuous ocular toxicity of antibiotics, and 3 mm perforation was noted, and I did glue BCL. AC was very well formed, but we may notice corneal vascularization, and this is 4-month post-op after removal of glue BCL. This another case is a 24-year-old male who had traumatic perforation, and this is the same at 2 and 4 o'clock. There is debris under the bandage contact lens, not the iris atrophy, and this is 4 months post-op after removal of glue and BCL. This is 60-year-old male who had Bell's palsy since childhood. Cataract surgery was done, and he has exposure keratopathy, perforated ulcer. I did TA, BCL, and tarsorrhaphy, and this is 1 year follow-up. Thank you.
This is a case of a decimetocele following foreign body trauma in a 33-year-old man also suffering from secondary amyloidosis with chronic kidney disease, sensory neural loss, and colloid goiter. His best corrected visual acuity was 612. Initially, a single layer of AMT, stromal side down, was applied using fibrin glue. Thereafter, multiple layers of AMT was placed over this and fixed using 10-0 nylon sutures. The patient maintained good vision and is currently on follow-up of about 3 weeks.
Praful, you are muted.
Thank you both the presenters for the excellent presentation. We have Dr. Nivet Lomi with us. He's going to highlight the positives and negatives about both of this presentation. Then we'll go to our expert panelist.
Thank you, Dr. Prabhu. Thank you, Dr. Gunjan and Dr. Gita. It's wonderful to see the videos of how beautifully the corneal perforation has been managed in case of this multi-layered AMG. And also, Dr. Gunjan very nicely presented all these the indications, the complications, and then the procedure stepwise. So one thing it is really is a definitive treatment, or it can be used as an interim procedure to delay the surgical repair when you don't have another option for penetrating keratoplasty. And this blue BCL with using cyanoacrylate blue it's a easy and very easy methods, and also easily accessible. However, said that there are few complications which can occur, like if you are not careful with while applying the glues, because they have a toxicity. If there is any iris tissue adhesion is there, they have to be released well, and so that the contact between the iris and the lens is avoided. They cause corneal vascularization and later on cause corneal opacity. So another second procedure might be required. So that consent, while taking the consent, it is very important to ensure the patient that he or she might require a multiple session. And also other complication, like if it is not, the glue is not placed properly, then like giant papillary conjunctivitis is very common. So this has to be kept in mind. And also, like the advantage of this cyanoacrylate glue, it is have also a component of bacteriostatic. So in case of infective pathology, it can be also be useful. Besides that, using this multi-layered AMG, it is it can in multi-layered AMG. It is useful because it's biodegradable again. And another disadvantage is that the tissue, it is not easily accessible, and you need an eye banking for that one. And the risk of transmission of infection is always there. So that has to be kept in mind. And the procedure is nicely described as shown in the video by Dr. Gunjan. Another way which can be done by using layers, multi-layer of AMG, and followed by a larger AMG graft to cover whole of the cornea, and then using either interrupted scissor and the continuous scissor, you can use that. These are some of the points which I could think of this regarding this presentation. Whereas I request any other expert panels to comment on it.
Thank you, Lomi. Any addition or comments from our panel?
One alternative is also a Tenon patch graft because it is autologous, and if external tissue is not available, such as amniotic membrane, then autologous Tenon patch can be applied. And
they have a talk, I think, later on this.
Next presentation was on that, ma'am.
Okay.
I think the cases were managed beautifully. If you look into outcome wise, and the initial two cases, the outcomes were wonderful, considering the fact she managed not only the perforation, the associated problems also, because it's not only the perforation which has to be managed. You look into the causative factor why it has happened. That has to be tackled so that patient doesn't have the other associated problem during that time or subsequently also. Like patient with exposure, the TAS or a few other good way to handle these cases. And you have to investigate these patients for a systemic autoimmune disorder, which may be the actual reason for having these small melting and perforation. The idea is to manage this small perforation and look for what was the actual causative, like a foreign body which led into this. That cornea will behave very nicely because there's no associated problems. Patient with a systemic autoimmune disorder, patient may not behave that well. So you may require a subsequent procedure also. The second case, I thought the glue was little larger and more irregular. So I think the sizing of a glue, which I think various techniques have been described, would also be a very important teaching for our people, how to size the appropriate size of cyanoacrylated glue for that particular area. As pointed out very nicely, you need to avoid the other ocular tissues so that you don't have inflammation going on. But looking at the outcome, it was very nice. As for third case is concerned, I would prefer a different way to manage. Like I would put a multi-layer AMG into that area of thinning or a perforation, which may be impending. Most of the cases impending, and do a suturing of that small multi-layer onto the area of thinning and perforation. Tuck it there, then put a one layer of AMG covering the entire cornea, and that will be a better one rather than putting a bulky, large, multi-layer AMG in such cases. Beautifully managed.
Thank you, sir. Dr. Paras?
Yes, can we have a comment from any of the CSI executives?
So I think Dr. Tityal rightly pointed out, we should have an idea what is the final destination which we are looking at. What are we trying to get from that procedure? So if you have an idea, like how Dr. Lomi rightly said that, okay, temporary, if you want to put it as a patch and then do a therapeutic corneal transplant, that's a totally different thing. But as Dr. Tityal said, if you want to use the multi-layer amniotic membrane as in fill in or stuff in and let the epithelialization occur on top of it so that the collagen bulk which is provided by multi-layer amniotic membrane helps you to sort of get a though thinner cornea, but some layer of the collagen there. And in that case, it has to be stuffed in and covered by an overlay. On top of it will not get epithelialized for sure. So either the sutures will get loose, it will come off, or you will have to remove and plan a therapeutic graft. So we should have an idea why we want to do what particular thing. I mean, but overall very nicely managed.
I just have one question. How do you, if your glue is not coming out, I mean, it doesn't come out on its own, what do you do about it then? Say 3 months down the line or 2-3 months down the line, it refuses to come out or refuses to fall down or refuses to disintegrate.
Dr. Gunjan, would you like to take that?
Yes. If it has to heal, in my limited experience, if it is to heal, it will heal in 2 to 3 months. And if it is I will remove it after 3 months or maximum 4 months. And if AC, in one case I had when AC got flat immediately, then I did a Tenon patch graft in the same case. If it is not healed in 3 to 4 months, then it won't heal.
I think one thing to make sure also that BCL related infection have to be taken care of. You have to have a close observation on it also.
I think BCL has to be changed, every fortnight if a lot of deposition happening. But
Yes.
most of the time, as Gunjan nicely described, most of the time the glue will come off with the healing has occurred from behind. But with no associated problems, you feel the healing is not complete, but there's no associated problem. You're not having any further corneal damage and there's not much inflammation. You can retain that for as long as possible because ultimately healing going to happen in these cases and it will come off. Rather than trying to pull it off and then you require another perforation and then management subsequently. Like Lomi said, if there's no GPC, no other problems, cornea is clear, no vascularization happening, then you can retain for a longer time also.
Thank you, sir. So I think we will be moving on to our next topic, Tenon's patch graft. So Shabina, could you play that video?
Good evening all. I'll be presenting a case of large corneal perforation managed with Tenon patch graft and TABCL. I'm very grateful to all the organizers and moderators for including my case presentation in this great forum. So a 60-year-old female presented to my OPD with complaints of pain, redness, photophobia for the last 2 months and increase in symptoms for the past 2 weeks. She gave a history of diminution of vision in the right eye since 2 years. Old records mentioned that she was a known case of primary angle closure glaucoma since 4 years with both eye PI patent, left eye operated trabeculectomy 1 year back with IOP controlled on 2 medications, and right eye was absolute eye since 1.5 years. She was using anti-glaucoma medication in both eyes and was diagnosed as corneal ulcer in the right eye 2 months back and was treated with multiple antimicrobials. There was no previous record of corneal scraping. There was no history of ocular trauma or any previous similar episode. She also had diabetes and hypertension, which was controlled on medication. On examination, right eye was PL negative and in the left eye, visual acuity was 6/18. Intraocular pressure was digitally low in the right eye and in the left eye was 18. On examination, there was lid edema with diffuse conjunctival congestion and a temporal pterygium. Adnexa was normal and Roplas was negative. Ocular movements were full. So corneal examination showed 360-degree superficial vascularization with peripheral radial folds. With the central, this was the central perforation, which was measuring 4 into 6 millimeters with an active leak with well-defined margins. The surrounding corneal stroma was intact. There was no evidence of any stromal thinning or necrosis or melting, and there were few infiltrates. There was a partial pseudomembrane. This is the pseudomembrane, which you can see. It was partially covering the perforation and was extending into the intact stroma. The anterior chamber depth was nil. Iris was completely adherent to the margins of the perforation, and in the central, air bubble was seen with lens not visible, and there was vitreous prolapse. So the clinical diagnosis was both eye primary angle closure glaucoma with right eye microbial keratitis with perforated corneal ulcer and absolute eye. Left eye was operated trabeculectomy with pseudophakia. A USG B scan was planned after surgery and corneal scraping was done intraoperatively after debriding the epithelium. However, there was no growth on bacterial and fungal culture. So the patient was started on empirical medical therapy and the patient was planned for tuck-in Tenon patch graft combined with cyanoacrylate glue at the edges of the graft and BCL. So why did I choose this procedure? Because the surrounding corneal stroma was intact to make a stromal pocket and there was no evidence of any stromal melting or necrosis. It was an emergency situation and the vitreous cavity was open. There was no visual potential. Cyanoacrylate glue alone was not possible because it was a large perforation and donor cornea or amniotic membrane was not available. So I decided to go ahead with this procedure. Patient was given an option of going to higher institute for corneal transplant, but due to nil visual prognosis, they were not willing. So I decided to create a 360-degree stromal pocket and tuck in the Tenon graft and then supplement the edges of the perforation with cyanoacrylate glue over the tenons. This will also avoid any intraocular penetration of glue, avoiding any intense inflammation. The recording system was not available with us, so I'm just showing another video of Tenon patch graft. So first we measure the size of the fistula and mark on the conjunctiva approximately 1 millimeter more than this measured size. Then peritomy is done and the Tenon tissue is separated from the conjunctival tissue and the underlying episcleral tissue. The Tenon's graft is then harvested and the cut edges of the conjunctiva are approximated using 2 blunt forceps. Following this, the surrounding epithelium is removed and the edges of the perforation need to be freshened. A 360-degree stromal pocket is then created with the help of a blunt crescent knife, and the Tenon graft is fashioned in a circular manner and placed over the perforation. Then the graft needs to be tucked whenever possible into the stromal pocket. In this manner, following this, interrupted sutures can be placed and the sutures need to be buried. So similarly, in this patient, the surrounding epithelium and the pseudomembrane was removed, vitrectomy was done, and a 360-degree stromal pocket was created. Then the harvested graft was fashioned according to the size of the perforation and was tucked into the stromal pocket. Intermittent radial sutures were then placed and anterior chamber was formed with BSS. All the areas of leakage of the fluid were noted and only those areas were supplemented with the cyanoacrylate glue as shown in this picture. Then AC was formed with air and BCL was placed. On day 1, we can see that the Tenon graft was properly tucked in along with these radial sutures, and these are the areas of glue which were supplemented at the edges of the graft. A superior air bubble can be seen. At 3 weeks post-operatively, the surface was completely epithelialized and was smooth. Properly tucked in Tenon graft was seen and vascularization was also visible. And the areas of glue, they became loose, so the glue patches were removed. At 2 months, patient was quite comfortable. There was reduced inflammation. She was free of any kind of symptoms. The surface was completely epithelialized and vascularization was visible along with the Tenon graft and sutures. So Tenon patch graft can be used for large corneal perforations in microbial keratitis if the surrounding stroma is intact with no melting or necrosis to aid in suturing and stromal pocket preparation. It also provides tectonic support in the area of perforation, and any area of peripheral or edge leak can be supplemented with cyanoacrylate glue. It should be used in eyes with visual potential in emergency situation if the donor cornea is not available, and can be preferred in corneal perforation up to 6 mm with no visual potential. It is also important to explain the opaque nature of the graft to the patient, and this image.
Thank you, Deepali. That was a wonderful video to show Tenon's patch graft, how it is done. So my few questions to the panelists will be, what is the largest perforation that can be managed with such Tenon's graft combined with glue? That is one point. And second, what would be the suturing pattern they prefer? Because I have seen few people, they don't use interrupted suture. Rather, they simply put stay suture over the Tenons. And
yes, Professor. Yes.
Yes. So I think Dr. Namta, you can take those questions. You have an excellent paper on this 31 cases series. So you can share your experience here.
Dr. Radhika is there. I think she wanted to discuss the Tenon's patch graft. Dr. Radhika, yes. No, Radhika, you're muted.
No, I was just mentioning in the context of an option that Tenon's patch graft is a very good option for such perforations because it's autologous and is available. The very nicely Deepali has shown the adaptation that you can do a hybrid technique where you take where you're worried about the glue going into the AC, so you may use the Tenon's patch in the center and then use the glue to augment from the side. So it's a good option. And regarding the suturing, yeah, the Tenons can be difficult to handle, and you also have to see the location of the perforation because you'll be using tenonylon on the cornea. Of course, these are emergency situations, and the first goal is to stabilize the eye. I personally feel that it is much better to put, unless it's a very small patch where it's very difficult to put multiple sutures. But otherwise, if you can put 4 to 6 sutures, it's better. But sometimes the situation would be that it's a very tiny tissue, the Tenons is difficult to handle. Then you can just put a cross suture and then, put a BCL on top of that.
Here, I would like to make a comment that this technique was pioneered by RP Center Group and especially Dr. Namrata Sharma and Dr. Rasik Vajpayee. And that has become, so useful technique for various perforations, and it saves our skin, especially in COVID times. It was absolutely useful.
Also, Dr. Praful Marana, he was also part of the thing. But
One of the, yes.
I think Dipali showed very well about the Tenon's patch graft and there are several questions which are unanswered, like, can you do it in microbial keratitis or not? And she's very nicely shown that you can do it. Can you do a larger perforation? And she's shown that you can do it, perforation as large as 6 millimeters. And like you said, it is very difficult to handle, but you can also do a tuck-in Tenon's patch graft where you just tuck in with the help of the glue. In fact, originally it was described like this only, that you tuck it in and then you put a fibrin glue. Only for the larger ones you need a suture, otherwise you don't actually need a suture.
Yeah, Perful, just one, Perful is off. Namrata, one question, what will be the interaction of this Tenon's graft? Suppose it is hanging in the anterior chamber with the uveal tissue. Would there be some inflammation with this in the long run? Because I remember seeing one patient, Tenon was hanging onto the anterior chamber and it was touching the iris tissue. Because other corneal tissue like fibrotic membrane or the desmids, they create such a inflammatory response, and you get an immediate synechia, all those things. What about this Tenon tissue which is hanging in the antechamber and touching the iris tissue? Because iris tissue will be coming towards the that perforation area sometimes, because it becomes a very floppy, and whatever you do, it will come to that area.
Especially in cases where there is perforation and iris tries to come
larger
in.
ones.
So I have not had a situation where this has happened, but I would think that there would be some amount of inflammation that would occur. I don't know if others have had a similar experience on this.
Can I just add? Yes, I have done this sandwich technique, rather putting Tenons on the iris and then putting glue. And it was a kid with severe dry eye, basically, and she had the liver some issues, so we couldn't take her to GA, and we had to do it under topical. So it was a very difficult situation, but the reaction was not that severe. But one thing that occurs with Tenon's patch is vascularization. If you have noticed Dipali's video, there were 2 vascular twigs entirely covering that Tenon's graft. So if the Tenon's is hanging into anterior chamber and it is communicating outside, then it's highly likely that in long run there will be intractable glaucoma, because that may induce your epithelial ingrowth as well as fibrotic ingrowth. So that is the risk. AC inflammation is not that severe, unlike cyanoacrylate glue.
Okay, I think COVID phase is over now. Given an option, you have both corneal tissue and Tenons. What would be preferred? You have such a large experience,
So I think it would depend on the etiology, sir. So for instance, if it is something like say a Stevens-Johnson syndrome with very severe dry eye and has a perforation, then we would go in for Tenons rather than going in for a graft, because that is likely to melt in the post-op period, whereas Tenons is unlikely to melt. But if it's not if it's a wet eye, say, and there is a perforation, then perhaps you can go in for a corneal graft. So basically, I think it would depend on the etiology. Dr. Science Group has published a lot on Tenon's patch graft for perforations which happen after in Stevens-Johnson syndrome. And I'm sure Paras also has a experience, or Himanshu has an experience in such kind of cases.
One can use even fibrin glue to, allow the Tenon's folds to stick together and stuff the Tenon's patch into the stromal tissue and put an infinity sutures instead of even interrupted sutures at the edges of the Tenons. It's a very good technique, and overall, we are all thankful to RP Center for bringing it to us.
Thank you, Paras.
I think the size, what Dr. Namrata said, is the clincher, that a very small patch graft becomes a little difficult to handle. Less than 3 millimeter is little tough to handle, and even the suturing becomes a little there. The Tenon patch grafts scores a lot. a little larger perforation, and if the edges are fine and if they are healthy, and as Dr. Namrata said, you're not seeing the progressive perforation, relatively quiet eye, well, I would certainly wish to do a corneal patch graft there.
So that is the next title of our paper then, in which cases do you Tenon's patch versus corneal patch in a randomized study?
Wow.
I think
In fact, in one
that would be
study,
necessity, and especially I saw that the first case which Dipali showed, that perforation was not very, very large. And that case could have been managed by the various other ways also. So there has to be some definitive, I think, sort of indication where actually, tenons would be the preferred ones. As Dr. Namrata nicely highlighted, SJS may be the one on a very poor ocular surface. Good.
Thank you, sir. I think we will move on to our next set of presentations. And now this will be covering PUK, how to manage a case of perforation when there is associated peripheral ulcerative keratitis.
This is a case report on how patch grafting saved vision in a post-peripheral ulcerative keratitis precious eye. The patient was a 56 years old Asian Indian male. He was a known case of type 2 diabetes mellitus and rheumatoid arthritis not on treatment. He was diagnosed previously with peripheral ulcerative keratitis of the left eye and had come to us for right eye cataract surgery opinion. Patient had already lost his left eye due to PUK, which led subsequently to microbial keratitis, causing a corneal melt and being treated with therapeutic penetrating keratoplasty. He was lost to follow-up due to COVID-19, presented to us with total loss of vision in the left eye. Right eye cataract surgery was done under immunosuppression. Patient developed PUK soon after and was initially treated with a glow BCL. Patient was again lost to follow-up. His next presentation was with a full-thickness crescentic corneal melt with glue being lost and BCL in situ. IVMP 1 gram 4 divided doses with glycemic monitoring was administered to the patient, and he was started on mycophenolate mofetil 500 mg twice a day maintenance dose, and patch grafting was done. Due to history of microbial keratitis and loss of vision in the left eye, conjunctival swab was done for the right eye and was found to have no growth. On presentation at slit lamp, right eye showed a temporal area of keratolysis with iris prolapse covered with a thin pseudocornea. Edge of the BCL was visible, but Siegel's test was negative. The ASOCT of the right eye at presentation showed a thin pseudocornea covering the prolapsed iris. Root of iris was visible inferiorly, as were adhesions between the normal cornea and the prolapsed uveal tissue. The irregular anterior chamber can also be appreciated in this picture. Patient's visual acuity was 6 by 60 at presentation. We will now see a short edited video of the procedure. The first step undertaken was conjunctival peritomy to find the exact extent of the perforation, taking care to not traumatize the iris tissue. Minimal cauterization of bleeders was done to obtain a clear field. Meticulous but gentle blunt dissection was next done to remove the pseudocornea, taking care not to injure or macerate or crush the underlying iris tissue. This step is one of the most important steps of this surgery. The adherent iris tissue was next separated from the cornea, followed by blunt dissection to remove uvea from sclera. We used a caliper to measure the extent of edges of the crescentic wound on the host, and graft was marked using ink-tipped caliper endothelially. Graft was then placed endothelial side down, and epithelial side was marked with freehand, followed by freehand dissection fashioning of the graft. Placing the corner sutures was the first step done to ensure continuity of anatomical landmarks and a good cosmetic outcome. Rest of the grafts were sutured conventionally to the host. All the knots were buried, and a subconjunctival dexamethasone and gentamicin injection was given in the end. The next picture which we will now see is the post-operative day 1 picture, and it shows the graft in situ, a very small air bubble in the anterior chamber, and the pupillary area and visual axis almost clear. This is the post-operative day 1 ASOCT, which shows iris edema and graft host junction edema and a newly formed angle of the anterior chamber. At present, patient has 6 by 36 parts visual acuity in the right eye. We had a few interesting take-home points in this surgery. It is preferable to do peripheral patch grafts. It is important to adequately size the grafts. Iris tissue can be saved for better anatomical and functional outcomes, and immunosuppression can be an important factor in increasing graft success and longevity. Thank you for your attention.
Hello everyone. I shall be talking about crescentic or banana-shaped patch graft in cases of Murren's ulcer. As we know, in Murren's ulcer, we usually have a peripheral corneal thinning associated with perforation in cases of periods of activity or following trauma, or sometimes when we see significant thinning after removal of the glue BCL. So this is our case, a 34-year-old male. Here you can see the area of thinning extends from 11 o'clock to 4 o'clock, associated with a large area of perforation of the cornea with significant iris prolapse and a flat anterior chamber. The patient was scheduled for a banana patch graft in order to avoid of large full thickness penetrating keratoplasty. So the patient can be taken in general anesthesia. In this case, the patient was taken in local anesthesia. Here we are first performing conjunctival peritomy in order to expose the area of thinning for a better visualization. So after this, a gentle cautery was done, again, which will enable us a better visibility of the area of thinning, as well as also will help us in suturing, particularly when it involves the sclera. So here we are dissecting the host bed in order to obtain a more regular surface, which will enable us a better graft host apposition. You can use a blunt crescent for it. The overhanging edges were cut in order to obtain a vertical edge, again for a better apposition. The inner and the outer circles of the thinning can be marked with a trephine. Here we have taken a 12 millimeter trephined donor because it was involving the limbus. After securing it, we are marking the area of thinning with a marker, and we will cut the donor according to the marks. So this is what is called to match and patch. We are matching the donor according to the area of the thinning of the host, and then we will secure it with fibrin glue and sutures, 10-0 nylon sutures. So you keep on adjusting the donor according to the area of the host thinning. The sutures here need not to be very long, and particularly in the areas of thinning, we should be very careful to avoid any full thickness suture. The knots may be preferably buried at the site of host tissue, avoiding the graft-host interface. So in this case, the host bed was very thin, around 100 to 150 micron above the test bed membrane. So we have taken a full thickness donor tissue. In cases where there is significant residual stroma of the host, we can do a laminar dissection of the donor. So as we are putting sutures, as we are patching the donor tissue on the host, we can see the AC is getting formed eventually. Here there is a large amount of iris tissue prolapse which is plugging it and maintaining the anterior chamber. In cases of small iris prolapse, we can reposit the iris, making a paracentesis port at the end of the surgery. We should be very careful while dissection about inadvertent perforation. And in cases of perforation, we can apply a fibrin glue or give an air tamponade. While dissection, we should keep the host bed dry so that in cases of aqueous ooze, we can locate it immediately. So this is the end of the surgery picture where we can see the AC formed and a beautiful patch graft over the cornea. So this is the 8 weeks picture. The patient was maintained on topical and oral immunosuppression, maintaining a good vision. The sutures can be removed over a period of 3 to 6 months. This is our second case of Murren's ulcer, again taken care by a patch graft avoiding a penetrating keratoplasty. However, in cases of advanced cases of Murren's, or where the thinning is non-progressive, or in cases of infection, superated infection or central involvement, full thickness keratoplasty will be a good option. These are the alternate management for corneal perforation. Thank you for a patient hearing.
Thank you both the speakers. Both the video covered two different aspects of patch graft in PUK. We have Dr. Sridevi Nair. She is working as an assistant professor in cornea unit. Sridevi, what's your take on both the cases?
Good evening, everyone. So both Amrita and Amita, they showed two very beautiful videos of how to handle a case of PUK. One and two very common scenarios. One is Murren's ulcer and second is rheumatoid arthritis or any PUK that is associated with the systemic autoimmune disease. So while all the important intraoperative steps were nicely highlighted, such as the conjunctival peritomy, removal of the epithelium, blunt iris dissection, and suturing, and also the graft fashioning. One thing that is a challenge in these cases is the post-operative management, because recurrence is very common, and maybe in up to 10 to 30% of the cases in Murren's ulcer, and one has to take some precautions to prevent this. So I feel that intraoperatively, one more thing that could have been done in both cases was a conjunctival resection. That is about 4 mm from the limbus and 2 cloacars on either side. That would reduce the antigenic load and can help prevent the recurrence of melt in such cases. And also people have described the use of a glycerine preserved cornea for using as a patch, because that has a lower antigenic load. It is acellular. So that is also one thing that can be tried. So in addition to that, the most important is your immunosuppression. So in case of Murren's ulcer, post-operatively, you should not be in a hurry to stop your systemic immunosuppression in addition to the topical steroids. So if it's oral steroids or even any other systemic immunosuppression such as azathioprine or mycophenolate, should continue it for at least maybe 3 to 6 months. And because loose sutures, recurrence, all these are very common in these cases. And in terms of the rheumatoid arthritis case, again, it may be commonly associated with issues such as dry eye. So the adequate lubrication and again, topical steroid therapy and systemic therapy for the rheumatoid arthritis should be a prime focus after the surgery, again, to prevent the recurrence and, help a good rehabilitation. Both the videos are really nice. And thank you. Thank you, Amita and Amrita.
Thank you, Sridevi. Any practical points from our expert panel?
Vanity? Dr. Vanity is there? Not there.
So, okay, so both the videos highlighted two different techniques of doing patch graft. So my question will be to Titial sir, according to you, which is the best one? Whether to go for manual dissection and take a patch or match and patch technique? Which one would be preferred by you while managing such cases?
I think, people have described both the techniques. And if you have a slightly, smaller size, then it is easy to, fashion out the shape of your lenticule, which is going to be put there. If you have a larger area going beyond the, 120 degrees, then it's very difficult to really match, because sometimes when you dissect out, things are larger than what you think. And whatever I've seen, whenever we're doing a patch graft in these cases, and next day or after a few weeks, see that adjoining area start melting. So whatever size you do is always smaller in these cases. I would rather go, into a normal cornea, at least 2.5 millimeter, covering that area also. Never think that with only the thin area has to be covered. You have to go beyond that and make sure that you get into healthy cornea.
She's my wife.
That requires the fashioning on the spot also.
Yeah,
people have described various ways to fashion out. As you said, automated fashioning can also be done. Sometimes, you may have to put an entire 360 degrees. You have a too large banana-shaped thing has to be done, because the area of normal area may become very small when you start dissecting these areas, because overhanging margin doesn't actually make you feel how deep it is. And when you start dissecting, that it's larger than what you feel. So always go larger. And most likely the freehand dissection is also very important in these cases, because on the spot you may have to change your sizing. And you have to have an extra tissue with you, because sometimes when you actually put suture, you feel it's smaller. Sometimes I have done multiple patch in the same area, because the initial fashion graft was smaller. It became smaller. When you start putting suture, it gets to one side, and the other area is left, uncovered. Then you have to fashion out another tissue there and do it. So those things are important ones.
Dr. Vanity is there, I think. Vanity? Actually,
Why your
no,
you
she
can
has a
answer that. Why your
publication on patch grafts, which
Yes.
she did
I
in
think
Corneal.
Radhika ma'am can also.
Dr. Radhika is there?
Ma'am
Or
is there. Any experience of doing sutureless patch graft in PUK? Ma'am, Radhika ma'am? Any experience of doing patch graft with fibrin glue in PUK cases without applying sutures? Because the concept is that suture also, they are traumatic. So they may induce lysis at those areas. So any experience of doing sutureless patch graft?
Sutureless patch graft you can only do if it's very small, only maybe 1 or 2 clock hours, because the moment it becomes crescentic, then you cannot, crossing 3 clock hours, and you cannot use a sutureless technique. But again, you can use a hybrid technique, because sometimes you'll find that there are a lot of, at the edge, for example, to get that edge to edge apposition, you may even have to bevel down the posterior aspect of the graft so that it, slips into the position. The other thing you can sometimes do, because some of the cases are quite challenging, they can sometimes be very advanced and very irregular in shape. So you have to take a call, as you correctly asked, whether to do manual dissection, whether to take two, because if you want a very uniform shape, you may have to use two trephines, but then you may end up taking dissecting more into the normal cornea. So you can even try you can take your donor cornea and you can align it on one side if it's a very irregular shape. On the other side, the transparent cornea is now lying over the diseased tissue, and you can mark out the shape and then cut it, and then further handcrafted to fit in. I would say that you should not rely on a sutureless technique if it's a larger perforation, but sutures do help. The glue does help to stabilize the graft also during the during the suturing process. So it gets stable. You can pass the sutures, and you can use a kind of a combination of sutures as well as glue.
Thank you, ma'am. I think Dr.
Praful, just one comment.
Yes, sir.
Sometimes you get to see these patients in a very early phase when you start seeing a little bit of guttering happening without the all those overhanging margins, and that is the time we talk about conjunctival recession to be done in these cases. So sometimes you can just fill that little guttering with the fibrin glue and put a bandage contact lens, recess the entire conjunctiva, which might work in some cases. That's a very early phase of disease progression happening.
Dr. Vanati ma'am, I think one of the most important point while doing patch graft in PUK is when to do the patch graft.
Yes,
So
I think. Thank you, Praful, and apologies, I was on another call. A very important aspect which is to be covered, especially if you're looking at immune melts, is always stabilize the immune activity before you do the patch graft. So you might need to do an acute immunosuppression in these cases, especially those which have systemic diseases here. You might need an acute immunosuppression either with an IV pulse steroid in combination with your physician to manage these cases before timing of the patch graft here. Otherwise, several times you would land up with a postoperative melt of these grafts, and you will need to do a regraft in these cases. Again, coming back to the earlier question of whether you would like to use suture-assisted surgeries, I think if you're doing lamellar patches, more than for large PUK-assisted patches, lamellar patches, if you're doing crescentic lamellar patches, and if you're doing tuck-in lamellar patches for something like a Terrien's marginal degeneration or a pellucid's marginal, there probably within a tuck-in procedure, a suture-assisted is going to be more helpful. A third point is to sort of match your host area. A good idea is to use small sized skin biopsy punches at the edge of your grafts to give you a real banana shape here. So that will really give you or help you in very good approximation, and will also help you to control the astigmatism, because several times I do find my residents that the edge of the grafts are usually tapering, and then the alignment and the suturing in that region usually goes a little haywire. So that's a small tip for some of my residents. I would encourage you to use small sized skin biopsy trephines there, and you can use them over the edges to give you a nice a semicircular appearance here, both in the host and in the donor grafts, and that really enhances your appearance and your postoperative management.
Thank you, ma'am. Any comment, Dr. Himanshu?
So, Amrita, one thing, I mean, the matching part which you did, I would do little differently. So, I think a few of them have reported the template technique. If I'm not mistaken, I think Anil Radhakrishnan, somebody had reported that thing where you put a drape on the area and fashion out the drape and put that drape on the donor cornea and cut it, which becomes much easier than putting a thick cornea on top of it and then trying to put the dots on top of it, which is a little difficult to I mean, I'm sure in your hand it would possibly work, but probably for a novice, a template can work equally well.
Yes, the stencil technique is usually very helpful. Yeah. The thin drapes which you get on your offsites you can use them to help in fashioning out your a template before you do the cutting.
Thank you, all the panelists. Now we move on to the last section. So we have covered small, medium. Now it's time to cover large and extra large. So Dr. Sarat is presenting one case of the therapeutic penetrating graft, and then there will be a video about dark in desmetocele. So Sabina, I think you can play both the presentations. Sarat, you can unmute and tell us a little bit about what was done in this case.
So this was a 28-year female patient presented with a left eye bacterial keratitis. She had 9 into 9 mm perforation with a 9 into 9 mm ulcer with around 4 to 5 mm of perforation. She was FAK, and the donor button came out to be streptococcus positive. So I did a therapeutic PK with donor trophine of 10.5 with 1 mm margin from the corneal ulcer and 0.5 mm oversize. So 11 mm of donor tissue trophine was used for trophining the cornea. So at the end of the surgery, I'm removing all the blood in the anterior chamber and completing the surgery. At the end of the surgery, I'm injecting some intracameral antibiotics into the anterior chamber. That's finishes the surgery.
Thank you, Sarat. Sabina, can we go ahead with the next presentation?
Good evening everyone. I will be presenting a case where we performed deep anterior lamellar keratoplasty in a post-LASIK desmetocele. So our patient is a 47-year-old male who complained of diminution of vision in his right eye since past 3 to 4 months. He had this peculiar past history of undergoing LASIK only in the right eye in 2012. On examination of old records, it was found that he had compound myopic astigmatism in the right eye and plano in the left eye. These were his pre-LASIK pentacam where thickness in right eye was 479 and in left eye was 498 microns. On examination, his left eye visual acuity was 6.6 plano and anterior and posterior segment was within normal limits. In his right eye, his visual acuity was 4/60. There was a central desmetocele. Anterior segment OCT done through the area of desmetocele revealed a thickness of 70 microns. CL trial was not done in view of risk of perforation. We also requested an autoimmune workup for him, which was within normal limits. Hence, we came to a diagnosis of right eye desmetocele status post LASIK, and right eye DALC was performed with manual dissection. Partial thickness definition was done with 8.25 handle trephine. Groove was then deepened with 300 microns guarded knife. First lamella was removed with careful dissection in the area of desmetocele. Dissection of second lamella was initiated from the area of desmetocele to the periphery in contrast to what is done regularly. Plane of dissection was created with blunt dissector. Viscoelastic was then injected to further create the plane between DM and the stroma. Stroma superficial to the plane was cut with 15 number blade, keeping the dissector beneath. And rest of the stroma was excised with Corneal scissors. Donor DM was stained and peeled off. Donor button was placed on the host bed and was secured with 18 interrupted sutures. His post-operative course was uneventful. Post-op 2 months, his BCVA improved to 624. All 18 sutures were intact with a clear graft. We searched for clues as to why did such melt occur in the first place in the histopathology report. It revealed a normal epithelium in Bowman's membrane with few non-specific inflammatory cells in the stroma.
Okay, thank you both the speakers for the wonderful presentations. We have Dr. Manpreet Kaur with us. She is working as assistant professor in Professor Tityal's cornea unit. Manpreet, what's your take on both the presentations?
Thank you, Dr. Praful. I think I'll start with the latter presentation first. DALC in a desmetocele has been described by our center. I think Professor Namrata ma'am and Tityal sir were the pioneers in that paper, and that inside-out visco dissection in which you go in from the desmetocele edges has been described. And in fact, contrary to, we feel that the desmids may be very fragile, it does have a good enough tensile strength, and the heaped up posterior stroma gives you a nice dissection plane where you can go in from the inside out and dissect where descemetic DALC can be done. And it's very interesting how desmetocele developed in this case. In fact, in the ASOCT, it's a post-LASIK case. I could not really make out if the LASIK flap was there in the periphery. So was a LASIK done or was something else done? I guess we'll never really know. And the vision improved to 624. So maybe it was primarily an amblyopic eye, because to have such an asymmetrical presentation in both eyes, intervention done in one eye only. So that's something that is interesting and has not been answered. Otherwise, DALC is a very good option in desmetocele with very good results. Coming to the first presentation, the therapeutic keratoplasty, of course, we have to follow the rules of clearing 1 millimeter of normal cornea beyond the infiltrates, and then the graft should be oversized by 1 mm of the defect. And you should conventionally measure again after you have performed your dissection, because the graft, the defect that is there may end up to be bigger than what you originally intended, because you're doing a freehand dissection. And length should be preserved if possible. I think this case was a phakic, but maintaining an anterior posterior segment barrier does help in therapeutic PK. And it was a very large graft, and 16 sutures often do not suffice. So do not be hesitant in putting more than 16 sutures if required. Otherwise, well presented cases and very beautiful surgeries, both of them. Thank you.
Thank you, Manpreet. So one point that I would like to ask the panelists, Dr. Nupur ma'am, you are here with us. So when you are dealing with such large perforation, what would be your protocol? Would you like to do a simple large graft, or would you like to add something like I have seen few surgeons, they would prefer to do a lateral tarsorrhaphy or put an AMJ, because large graft, the epithelial adjustment may not be that good. So what's your take on that? Especially when you are doing graft more than 10 mm. Dr. Nupur.
Thank you, Praful. I first should congratulate both the surgeons, very beautifully done surgeries. And on these therapeutic done by Sharad, which was a large graft, you're quite right that you will have a limbal stem cell deficiency. So putting an amniotic membrane graft would actually, so Sharad, how long has this patient, like when was the patient operated? What is the outcome?
Sharad?
You're muted, Sharad.
Sharad,
patient was operated around one and a half year back, and the outcome was good. She was finger counting close to face, even though she was aphakic. She was lost to follow up later on, and she had secondary glaucoma. So she had a ONH cupping of 0.9 at present, and hence the prognosis for an optical peak is not there.
Perforation, can I make a comment?
Graft remained clear after the 1.5 year follow up.
Graft is clear only,
So
ma'am.
it looked
Graft
very
is,
nice when
yes,
you were
ma'am.
grafting. Oh, great.
Just one comment on a therapeutic graft, and
Graft is still clear. I was hoping, but the prognosis was not good because of the secondary glaucoma.
as you saw a beautiful video on dog being in a desmetocele, and they put a very nice Flavinger ring. I think it would be a much more requirement for such a large therapeutic graft to put a ring in those cases, which will safeguard the massive complication which can happen in these cases. And especially in such a chronic infective disorder, which may be fungus, like we described the use of cross-linked donor cornea for such cases, which gives you a much more safety in the long run. And subsequently, Radhika Natarajan have described the actually cross-linking the entire cornea after doing the graft also. Even that's a good idea because it goes beyond the graft, and it also takes care of host graft junction other areas also. That can be considered in a very chronic fungal infections because that will safeguard both the parts. And desmetocele, I think Namrata can make a comment there.
So I think, sir, that was again your idea, and viscoelastic assisted.
In fact, my first DALC was,
in
through this desmetocele cases, which gave me a confidence I can do, actually desmetting DALC in our cases,
I think long time ago we did publish a whole series of it. And again, in a desmetocele, it is very easy to peel the layers which are already diseased. They are actually just waiting to be stripped. You don't have to do much effort, unlike a case of keratoconus, where you have to be really careful. So I think that was a beautiful paper, and that technique advantages, which again very beautifully shown even in today's video, that by a single stage procedure, you visually rehabilitate the patient as well as tectonically stabilize the patient.
Very nice and clear demonstration with that video. It was wonderful.
Thank you, sir.
Thank you, sir. So taking the last controversial question about therapeutic PKP, Dr. Himanshu, what would be your protocol for starting steroid in these cases post-operatively?
So again, it depends on how comfortable I am with the primary infection. So do I have a culture report? Do I have sensitive antibiotic which is responding to my treatment? I'm talking about the bacterial part of it. And now, if not, and if it is something which is going out of the hand, and that's the reason why we are doing a therapeutic graft, I wouldn't be very encouraged to start steroid immediately. Second, if it's a fungal and if I've taken out the entire infection and I'm sure about that I've got the clean edge all around, I would possibly wait for a couple of weeks. Again, I think Dr. Prashant Garg has published in that the maximum recurrences were there after starting the steroid was within 2 weeks. And if we are able to pass through that period, that's fine. Our primary goal is to get rid of infection and save the eye. Graft survival is secondary goal. So I would rather prefer that the infection is taken care of and eye is saved. Graft survival would be the next to it.
Thank you. Just to update details, sir, Dr. Radhika Natarajan is here with us and she is thanking you because I think you mentioned her publication that CXL with therapeutic PKP.
She does a wonderful work, we appreciate her work,
She is giving all her expert comments in the chat section. Thank you, ma'am, for that. Dr. Paras, I think we are done with our cases. Now it's up to you.
If we have any comments from any of the panelists about any of the cases, we can take that and then we can just wrap up the session.
So if no comment, then I would like to put one question that is there in the audience chat box. If you have options of glue BCL, AMG, tissue, everything with you, and the perforation less than 3 mm, which one would be your preferred method to approach that perforation?
You are asking us, Praful?
Yes, ma'am. All the panelists. Then we can conclude. Let's start with Sir. Titian, sir.
Sir.
Yeah, I'll refer this case to Praful and Namrata. Because all these cases are very tricky.
That's a good one.
Perforation management is a tricky management. It's not very simple. And before jumping on to any one of a technique which you like to do it, at least assess your case appropriately, then think and what would be the best option for that case. You can't really go with one technique for every case. So it may be small perforation, but you may have a different etiology behind that, as Dr. Namrata talked about. Then apply that technique for that. So I would rather think of what is the actual etiology behind of having that perforation, then think of applying your case. So that we discussed very nicely, which will be the good option for those cases.
Thank you, sir. Radhika ma'am, Damta ma'am, you were saying something.
No, Dr. Radhika. Then I will say.
Yes, Radhika ma'am. Ma'am, given a choice that all the possible options are there, what should be your preferred for small perforation, less than 3 mm size?
I would say definitely less than 2 mm size. I would prefer glue. And it's not only a question of the size, it's also the location and I don't know if there's iris plugging it, etc. But generally, I would say a small perforation is my first choice.
Namta ma'am?
Like I said, I would prefer glue as a first choice.
Vanati ma'am?
I think, as rightly pointed out by Sir earlier, it's not only the etiology, but it's also the morphological configuration of the perforation which needs to be managed. I think we have a paper way back where we talk about the various contours of the patch grafts. We have lamellar, mushroom patch grafts, and then we have full thickness patch grafts. And so I think you need to assess the depth of involvement which needs to be covered. So if it's a superficial one here, then and it's a small perforation, a glue works well, provided that the bandage contact lens and the glue are going to be staking on into your position. But if you have lid abnormalities, if you have conjunctival problems, those are not going to allow your bandage contact lens to sit comfortably over the glue area. And again, the application and the contour of the glue application is going to be very important to have your bandage contact lens sit there and allow healing over a long period of time. This primarily is one of the important reasons for failure in several cases when you find your residents doing these, and then they would resort to a patch graft in such cases. So I think you need to really assess the etiology, the morphology, and the technique you're adopting when you're doing a glue with BCL application before you're moving on to consider other options.
Thank you, ma'am. Dr. Nupur, what would be your preferred choice?
I would just actually glue BCL will work in most of the cases, but I would like to complete the list by including the smile lenticule, which is in places where we are doing smile refractive surgery, it can also be used. So we've just concluded a thesis, basically a dissertation on comparative on Tenon's patch graft and smile lenticule, where we've seen that smile lenticule is not as good for a full thickness perforation. They're good for desmetocele or a corneal thinning procedure, where Tenon's patch graft does work for all cases, even perforations. However, the ocular surface, if you see, is much better with the smile lenticule. For thinning procedures, we should actually use a smile lenticule. It actually blends very well, leads to, maintains the corneal transparency, no vascularization. So depends on case-to-case basis, but that will complete our armamentarium for small perforations.
Dr. Himanshu and Dr. Paras, what's your take on this?
I think we have included the entire session about this thing, and you beautifully included all possible combinations. So we are spoiled with choices. So I really don't think I should have a separate opinion about it. But one thing I just would like to just reiterate that we should have a final destination in our mind. What do you want to achieve from that particular procedure? Now, doing an amniotic membrane transplant, you're not going to get tectonic support there. How long that amniotic membrane is going to last on the surface, and what are you going to do after that? We should have that in our mind. So doing a procedure is maybe possibly not that difficult, but keeping in mind what to expect from this and what is the next step and what is the final destination, I think that's very important.
Yeah, I would totally agree with Dr. Himanshu, and maybe you could even have plan A and plan B also in place. When you plan to do a tissue adhesive and BCL application, sometimes if the bed is not very healthy, maybe probably you could end up into doing a Tenon's graft. So you should have the second plan also available and a separate, spare tissue also available for the such cases, tricky cases.
I think Dr. Paras now is.
I think we have had a great, wonderful session with all the practical tips. First of all, I would like to thank all the presenters for bringing in variety of cases. Would also like to thank Dr. Praful for being, such a wonderful moderator. Would like to thank all the, stalwarts for being here. We see these faces many times at various platforms on academic fronts, and we were very fortunate to have them here for this session. At the same time, I would also like to thank all the presenters for all 4 sessions which we had during this, whole year, and all the panelists and all the, discussants for being here and discussing, and bringing out various practical points for such topics which are generally not covered during, mainstream conferences. All the topics were, so helpful for everyone. And one can look back at those topics as this stays onto the, video library all throughout. So especially, I would like to thank Dr. Professor Titiyal for being here, despite, his, an ill health very recently. We are very happy to see you, sir, in such a great form. Thank you, sir, for being here with us. Dr. Himanshu.
I think there's something which we always look forward to, and in that, I would put a big list, and in that, the top of my list would be Kera Grand Rounds. And Paras, you have to be given all the credit for that, how meticulously you chase everybody, how you plan everything, how you decided about having videos so that the sessions are crisp, and all those things which you did throughout the year. God willing, we should be having this thing continued in future also. And we wish that you take it further beyond all this thing. And from all of us from CSI, I would really like to congratulate and thank you for whatever you've done with Kera Grand Rounds, and kudos to all.
Thank you,
It's
Manju.
just, unnecessarily giving me credit. Most of the time.
No, you are the one who changed everybody. No, but we
thank
should
you so
have a
much
season
for,
two. We should have a season
so
2.
generous about it. Yeah, thank you so much.
Thank you, Dr. Namrata. Dr. Namrata has approved that we should have the season 2.
Season 2.
Thank you. Okay, season 2. Yeah, and we thank, the back office team of CSI to, conduct these sessions very well all throughout without any technical hitches. Thank you so much and good night, everyone.
Thank you.
Thank you so much.